training at the University of Missouri. He's currently AO Spine MENA Educational Office and board member, and also president of the Pan-Arab Spine Society. And Sameh, if I was Marilyn Monroe, I would say congratulations, happy birthday, Mr. President, because I know it's your birthday today.
Well, thank you very much.
We are very happy to have you here.
Thank you very much, Oscar. I appreciate it. Thank you, Mohammed, for the invitation. And for the sake of time, let me just start right away. So, Addison's segmental disease is not something as horrific as some of the complications that we saw earlier. Vertebral artery injury, esophageal injury, those are stuff that you should really worry about during your surgeries in any anterior approach of the cervical spine. So those are my disclosures. I consult for a few companies. I sit on the advisory board of others, but none of those are related to what I'm presenting today. Now, I think when we talk about Addison's segmental disease, it is worthy to spend a minute or two talking about the difference between Addison's segmental degeneration and Addison's segmental disease as described by Alan Hellebrand. Because basically, Addison's segmental degeneration is a degenerative process that you see in your radiographs and your MRI, and it's usually asymptomatic. But the moment you start having new symptoms, including new radiculopathy or myelopathy or a combination of both, as a result of the pathology happening at the level above or the level below, then this is when we call it Addison's segmental disease. And why is this important? Because when we review the literature, you realize while the incidence, the annual incidence of Addison's segmental degeneration ranges between 3% to 11%, the incidence of Addison's segmental disease is much lower than this, and it ranges between 0.7 to 3.7%, which is the number that we talk usually to our patients about. Now, we all remember that very famous paper by Alan Hellebrand that was published in the JBJS a number of years ago. And this paper is very important because this was the first time we realized the number 3% per year, right? But when you ask spine surgeons, what do you remember from this paper? Is it 3% per year an incidence of radiological degeneration or symptomatic Addison's segmental disease or a 3% reoperation rate? And the truth is, very few surgeons would tell you that 3% in this paper was meant to be for the rate of symptomatic Addison's segmental disease that happens following anterior cervical surgery. So the question is, how can we avoid this? And if you're presenting this in a room full of surgeons, whether it's an orthopedic surgeons or neurosurgeons, the most common answer that you would get from the attendees in that room is, well, go ahead and use an artificial disc replacement because it's probably something that will decrease your incidence of Addison's segmental disease. Now, don't get me wrong. I love the technology. I love artificial discs. I do a very good number of them every single year. But let's dig further in the literature and see if this is really correct. Now, if you look at that narrative review, the famous narrative review that was published by Dan Rue a number of years ago in the Yellow Journal, the Journal of American Academy of Orthopedic Surgery, let's take a look at the numbers over here. So they looked at the different studies of cervical disc replacement that compared the incidence of Addison's segmental disease in cervical disc replacements versus ACDFs. And you can see here the minimum follow-up years was 2 years apart from that Prestige Medtronic study that was all the way up to 5 years. Now, while Addison's segmental degeneration was significantly higher in the ACDF group in comparison to the ADR group, yet when it comes to Addison's segmental disease, which is the one that we really care for, there was absolutely no statistically significant difference between both groups. Now, let's take an even deeper look into that. When we take a look here at the anomaly studies that included a 2 to 4 years follow-up of 3 prospective randomized trials, once again, there was absolutely no difference in the incidence of Addison's segmental disease between ACDF and TDA. Moving on to the Maldonado trial, once again, he divided his into 2 groups, 105 ACDFs versus 85 ADRs with a follow-up of 3 years. 10% of the ACDF group developed Addison's segmental disease versus 8.8 in the ADR. And once again, there was no statistical significant difference between both. Now, if we move to the Courage study, 41 ADRs versus 33 ACDFs, 4 years follow-up. And believe it or not, the Addison's segmental disease was higher in the ADR group versus the ACDF group. But once again, it was not statistically significant. So why is it that we think that ADRs are protective against Addison's segmental disease? Because when we take a look at the data, it doesn't really reflect what we think it is. It's basically because the majority of the ADR studies are industry funded, and there is a lot of room for potential bias over there. If we take a look at the majority of the RCTs that were done on ADRs in the past couple of decades, you'll realize that at least one of the authors has a potential conflict of interest with one or two of the companies that were involved in the studies. And we know very well that the FDA studies on TDR are some of the most biased studies that were published in spine. So Daniel Lebowski and Ed Benzel, a couple of years ago in spine, they decided to critically review the literature on ADR versus ACDFs for adjacent segmental disease and take a look over there because the numbers are shocking. So when you have studies that involved conflict of interest of one or two of the authors, you realize that the incidence of adjacent segmental disease in ACDF is almost threefold the incidence of ADRs. And when you review those studies that don't involve any conflict of interest, you realize that the incidence of adjacent segmental disease is almost the same between ACDFs and ADRs. Now, on a side note, and I know that's not our topic today, but even heterotropic ossification, when you look at conflict of interest studies, it's like 1 in 5 patients is going to develop that. But in non-conflict of interest, is actually double of that. So it's much higher than what we think it is. Now, some of you would probably say, well, if there is no difference between ACDFs and ADRs, why is it that we're using ADRs nowadays? It's because there is a lot of potential for the technology over there, but it's probably not as protective against adjacent segmental disease as we thought it is. Now, let's look at the pathology from a different point of view. Is it a natural history process? Is it that every single patient or every single human patient out there is going to get degeneration of the disc of his cervical disc, no matter what you do, whether you're doing a fusion, doing a disc replacement, or doing nothing? And let's take a look at a couple of studies over there. So this is a study that was done in 1990 comparing ACDFs versus posterior from anatomy with a 4.5 years of follow-up. Now, while 40% of patients who had an ACDF developed an adjacent segmental disease, it's interesting enough that even the foraminotomy patient developed, 50% of them developed adjacent segmental degeneration, and there was no correlation with the clinical symptoms. Here is another study over there on posterior foraminotomy where they had almost 850 patients with radiculopathy. Once again, none of those patients had fusions, and they had a prevalence of 9% over 3 years with an annual incidence of 3%. And remember, no fusion was done for any of those patients. Here is another study comparing anterior cervical discectomy without fusion versus ACDF, and the annual incidence was 3% in both groups, whether you had a fusion or no fusion. And that pushes me all the way to a very important study that was done by the Degenerative Knowledge Forum in AO Spine a couple of years ago, and that was back then when Jeff Wang was chairing the Degenerative Knowledge Forum in AO Spine. So this is probably one of the largest studies over there, and they did an analysis of the magnetic resonance imaging of more than 1,000 symptomatic patients. Now, the results are very interesting. So if you take a look at this chart over there, you realize that as we get older, every single cervical disc that we have in our cervical spine is going to degenerate no matter what. What we also got to know from this study is that the most common levels that are going to degenerate are C5-6 as number 1, followed by C4-5 and C6-7. We also got to know that it's very likely that if you have 2 levels of degenerative disease, it will probably be C5-6 and C6-7. And if you have a 3-level disease, it will probably be C4-5, C5-6, and C6-7. Now, that's very interesting because we know that the famous paper that I mentioned earlier by Alan Hillebrand, and that paper was probably cited more than 350 times already. They mentioned already that you're going to get an adjacent segmental disease 3% of the time in patients that you operate on with a fusion surgery. But we also worry about that number, but we rarely look at the conclusion of this study. So if we read the conclusion of the authors, even in that very famous study that was cited more than 350 times, the authors concluded that they believe the risk is related to natural history of cervical spondylosis rather than to failure of the operative technique. And that's very, very interesting. Now, this this slide particularly is from one of Jeff Wang's presentations. And if you take a look at the left side versus the right side, so if you compare the outcomes of the Knowledge Forum study versus the outcome of the Hillebrand study. So Alan Hillebrand mentioned that the two most operated levels for adjacent segmental disease are C5-6. And what's interesting is the two most degenerated level, as I mentioned earlier, are also C5-6 and C6-7. So that tells you something. There's probably more of a natural history. It's probably more of a degenerative process, more than it is of a pathology that's happening as a result of fusion or any other anterior approach that you do in your patient. Now, jumping to this study, and this is probably one of the longest follow-ups that we have in cervical spine. This is a 20 years prospective longitudinal study of a cohort assessed using MRI. And once again, they reviewed 193 patients. They followed them over 20 years. And once again, they came to the conclusion that every single cervical disc in your neck is going to degenerate. And it's probably a natural process. It has nothing to do with the type of surgery. So some of you would probably say, well, he already mentioned that ADRs are not protective. There is no difference between ACDFs and ATRs when it comes to the incidence of adjacent segmental disease. Every single level is going to degenerate no matter what you do. It's a natural process. So the truth is there really anything that we can do about it? And my answer to this is there are a couple of things that you can do that can prevent iatrogenic adjacent segmental disease. And there are two of them that are published in the literature. So the number one that I want to highlight here is your needle positioning. So whenever you place that needle in this space in a trial to identify the operated level, what Ahmed Nasr did and the colleagues from the Mayo Clinic is that they retrospectively reviewed 87 patients who had a single or two level ACDF, and they realized that when you place that needle in the disc space, you increase the risk of degeneration at that level by 3-fold. So it's probably a good practice when you're doing those to place that needle in the vertebral body instead of the disc space to prevent the earlier degeneration of the level above or the level below. The other thing is the plate length. And I know all of us have seen such x-rays, longer plates and ossification happening at the level above that tend to progress over time. Now, Dan Rue did examine this extensively. So they reviewed the lateral radiographs of 118 patients, and they realized that whenever those plates were less than 5 millimeter distance from the level above or the level below, they had a greater chance of developing that adjacent level ossification. Now, it's very important to highlight that also there was no direct correlation between symptomatic adjacent segmental ossification and the outcomes of those patients or the symptoms of those patients. And based on that, they advise that whenever you're using those plates, try to stay away 5 millimeters from the level above and 5 millimeters from the level below to decrease that incidence of ossification. So bottom line is all your discs or your patient's discs of the cervical spine are going to degenerate over time. It's probably more of a natural process than it is related to fusion. And believe it or not, adjacent segmental disease happen at the exact same levels where degeneration tends to happen over the years. ADRs, I love the technology. I know Oscar loves them. He does a wonderful number of those every single year. But remember, an ADR done in Oscar's hand, an ACDF done in a regular surgeon's hand might be better than an ADR done in another surgeon's hand. So not everyone out there is Oscar Alves doing ADRs on those patients. And if you are marking a level with a needle, try to place that needle in the vertebral body instead of the disc space. Now try to abort plates. They're not that great, by the way. All right. If you are one of those people who are using the bony cages, then it makes a lot of sense to use plates. But if you're not, we have a lot of technology nowadays with the standalone cages that can maintain your height and can reach the same level of fusion that you can get with plates. We heard my colleagues earlier talking about the incidence of dysphagia with plates as well. But if you are to use plates nowadays, so try to make them shorter, stay away from the 5 millimeters from the level above and the level below. Thank you very much.
Thank you, Sameh. Wonderful presentation, and thank you for the compliments. Everybody knows that ID studies were biased, and you very elegantly showed that. But there is also already a lot of real-world data that shows you that ACDF clearly have more adjacent segment disease than arthroplasty. And obviously there are many factors related to that, as you've shown. I'm convinced that most of that is really degeneration, just aging process. But there are other factors that it's not only the hypermobility on the adjacent levels that comes with ACDF,